adduction, you always want the thumb to be towards the ceiling. And then abduction. Side here. Here's the throwers. There you go, and you always want to be directly down, as well as following the fingers.
Why do you want the thumb up? To clear. What are you clearing? Right.
Then for extension, same thing. Actually, his thumb will be in the same direction. Same thing. Following the humerus and going down into the floor. Then I do the athlete IR. So I call it hand behind back. So you're using your thumb and you're just going as high up as possible. All right, let go. So then I'll show you guys too. I like find what segment they are and write that down. And I compare both sides. And he's way higher.
To like the spine or the ribs.
Yeah, so like, all like wherever he was, I'm here. What is the inferior border, the inferior angle of his head? Yeah, so then I usually compare that, find that, and then have to palpate downwards. Face the other way.
It's not uncommon for your buttocks that are really tight or painful if you have to document 2 lateral buttocks.
Yeah, or like yeah. Especially with that piece of capsulitis, so many people like can't even get to their sacrum when they have that. So here, and measure, there you go. And also measure this side, see how much higher it gets. Yeah, so then relax. And so then I'm like, okay, T2, come over. That's probably like T4.
Are you usually more restricted on your dominant or dominant?
So he's a thrower. Was a thrower. So he's definitely gonna have less internal rotation. But
You guys answer. Are you more restricted on your dominant? Yes. About how many levels do you think?
2 to 4.
I'd say a couple. 2 or 3. Yeah.
Yeah, and for formal athletes to catch this, we don't want them to reach their hand up to the bat for this.
I just go as smoothly as possible. You don't want to do like side bend or anything like that. You want their trunk to stay as straight as possible so that they're not like compensating. This is more of a functional measure than straight up internal rotation that will also go into it. Sound good? And then same thing for ER. It's this way. Emily went down, and I still try to use the thumb as much as possible. Just have them go down. Thumb. There you go. Relax. Same thing, I'll come across. And then I do this side as well. He has good posture the whole time. And you can do the standing as well, just gotta be careful how much they're arching their back. And so when you're measuring, they're arching your back, you might want to go along the actual trunk, then straight down, because it's different. Oh, and then I like to do this more passively for more accuracy, but horizontal adduction, abduction. So they're sitting nice and tall, and then they'll be here, thumb up, and he going across the body. Do you have any pain with that? And same thing, abduction, how far back can they go? You're just measuring for pain with that and like comparing to the other side.
You can put the goniometer on top and you will measure the amount of horizontal ab and adduction.
So like do abduction. Then I can come here.
That's how I typically see people
And then I just
measure it.
kinda
They do it in
I don't want to
sitting.
compensate.
Purely action.
Yeah, so that's why horizontal, like passively, is a lot better because the scapula is moving. So you try to limit the movement when you're doing it passively.
For your shoulder patients, because it's been a reason when we covered like abduction here, most patients probably didn't get that. So would you do horizontal ABAD because that's more?
Well, it's a different
Yeah.
plane that you're working in.
Yeah.
So
makes sense.
rower, yeah, I'm gonna get them up here because they're back here all the time. But if you have somebody else that's not working overhead a lot, you can do both ways to see where they're at. But I mean, that's gonna be your call when you come in.
And it's important just to compare both sides. Yeah, he might be limited, but is he limited on both sides, which is just has me in pain. So it depends.
How can you use abduction range of motion though to differentiate between soft tissue and joint?
Active and passive.
Okay, active versus passive, but what about like a differential? Like if I have pain with this, it's this. If I have pain with at this point in the motion, it's more likely that. Painful arc, right, is what you're saying. So if I have that 90 to 120, what if I have pain way up here and pain with this? What's the most likely? AC joint.
I have a question just about like technique. How important is it that you like put the goni on first and then like follow them up?
So-
as far as just like taking the measurements.
However you want to do it. I'll be honest, I will get them in the position first, stabilize them there, or have them get in that position, and then I'll put the going on and just measure up to that spot. I'm not going to take it through the full arc. I mean, I'm just going to put it up and measure to find where my fulcrum is, on my stationary arm, have my moving arm on where it's supposed to be. I'm measuring it through there. There's times where you're going to do passive stuff, and you're going to need somebody else to help you out to measure it. I mean, to get an accurate measure. I mean, we help each other out all the time in the clinic. Don't be afraid to ask, hey, I need help with this. But I mean, it's difficult. I have guys where I worked with a football player. He was 6'5", 320 pounds, and I couldn't measure his hip flexion passively with a goniometer in one hand. I mean, he was a massive kid. So you're gonna have to find ways to whatever's most comfortable for you, where you can get an accurate measure.
But I will say early on, it is nice to start there and then have them do it, because if people are in pain, they're not going to want to stay here in pain until you find exactly where you need to be. If you're already there and all that you have to do is when they move, you only move one arm, it's quick and it's done with. And then also, like, sometimes it's like, ooh, you know, just like finding where the axis is easier when they're just stationary before you move. So then if you're keeping that still, you could just move this. So I recommend that. But it's kind of like what's easiest. Everyone does it differently. Any other questions before we do passive?
Make one comment to that. You range of motion and muscle testing are great to assess, but in isolation they mean absolutely nothing. Unless you tie them into function, that's where and then you have that size of pain. So if you're just measuring stuff, just to collect data, that's research. You know, if you're going to use it clinically, collect the information that's going to be clinically significant, then put together the pieces of the puzzle for a good intervention plan, document it well, and you're sure problem payment that way. But if you're just measuring all these range of motion things just to take measurements, you're wasting your time because they don't mean anything. The grand scheme, make sure you tie them to the laws of function. That way you're looking at the overall picture.
And who your patient is important too, right? So, in the baseball player that I see in the clinic, I'm going to make sure that I measure internal and external rotation to make sure that they're the same on both sides. But for the lady that owns a deli shop that I helped yesterday, that's 60 years old with shoulder pain, her total IR, ER, flexion range of motion doesn't really matter to me or her at all. Right? So I'm not going to waste my valuable evaluation time measuring those motions on her, but I'm going to make sure that I spend that time on
Yeah, we're gonna go on to passive.
Alright, so passive, I'll usually do most of it all supine position with the patient. It's a lot easier for me to stabilize them. I don't have to hold their body up, but it raise them up. So you have to remember when you're doing flexion of the shoulder, you're getting that scapular upward rotation also. So it depends if you're just looking for pure glenohumeral motion or if you're looking for scapular, just scapular thoracic with glenohumeral. Is what you're normally seeing if somebody functionally is going to get up. You're going to want to do the whole thing. So I'm going to get up until I start to see she starts to compensate. You'll feel them, you'll hit like in range. Your scapular starts to pop up off the table, so that's when I'll go in. I'll on, find my position, get it with the mid-axillary line of the body, and up through the humerus. So same thing if we get it there. Internal rotation, which I do need to. So if we slide them out, usually I'll take a towel so that I make sure that they are level, because a lot of people, if you have them here, you're getting internal rotation, you're really not getting their full actual internal rotation, so making sure that their arm is level with the table. And we'll go in, this is one that I'll usually have somebody else help me with, but you can go in, you'll internally rotate until you feel them kind of pop up, which you'll feel as their scapula will start to come up and you'll start to see them around their shoulders forward. So that's when I'll take that passive range of motion. I'll go in and measure through there, which your stationary arm would be straight up, and then your fulcrum would be right on the electron process going through the ulna. External rotation would be the same thing, just the opposite way. So having them, they'll fall back. You can see how, you guys can see it all. She starts to pop up here. You can see how I'm hitting this end range. Those popping up, and that's when I'll stop and I'll make sure that when I'm taking my measurement that they're held in that position. The other one would be horizontal. What's up?
Do you ever do this one sideline?
So I usually don't do it sideline. I like to do it in 90 degrees of abduction. I can do it here also if you want to do. You can do it down that side. They can't get up that 90-degree range, so I can do it at 0 degrees.
Or 45 degrees, just depending on where they're at.
Yeah, it also depends on where you want to take their functional range up to. Does somebody work down here, they have a computer all day, or are they up here? Horizontal adduction, what I'll do is we'll have them here. You can stabilize, you can bring them across, and then once you start to feel their shoulder rounding up, coming over, and compensating through there, you can stabilize at the scapula if you want, so you see how their body's starting to rotate through there. So you'll take it and you'll measure. Put the axis right through the humeral head, with your stationary arm straight up, and then you'll measure coming this way. I would probably play. Most of my passive range of motion stuff I'll tell you is I usually have somebody else do it. Because this, you can see, it's kind of hard for me to come in here, stabilize, and take an accurate measure. So I would get good at, with your partner, somebody stabilizing them, and then somebody measuring it, and then flip rolls on it. So groups of 3 might be a way to help you guys out with that as well. And then, right? So abduction will come up, we'll stabilize right on their scapula, right above the AC joint. And we're gonna bring them up until we start to feel them move. So their arm will come up and then their trap will come in. What you'll do is when you're passively holding them in, you'll feel that their scapulothoracic joint is just not going to allow you to come up anymore, so their body will start to laterally shift. So you're going to pull them there, and you can measure it. You're going to take your fulcrum, put it right in the center of that joint. This is going to go even with the body, straight down the side of their body, and then your moving arm is going to come straight up through the humerus. Anything else?
No.
I missed anything on there?
But like on your question, so because there's only one of him, he has to do the whole measurement after he's already there. So it kind of just depends.
And then I guess we'll sit up. So I'll do horizontal abduction sitting, because you can do it with them hanging off the table, but I just like to do it sitting. So if she's sitting here, so that nice and straight.
Okay.
So we'll take them here, up in 90, come back here. And my measurement will be, you would do it's hard this way, but I can come straight out this way, where your stationary arm is now coming out. So 0 degrees would be if I was straight, and then your moving arm is going right through the moving arm humerus, your fulcrum is going right through the head of the humerus, right at that front of your arm.
You could probably do the same thing here if you didn't have anyone else to help you with your supine.
Do you passively do the apply?
No, I usually don't. I personally don't do the athlete. I mean, it's just a personal decision on what you guys do. I also wasn't taught it, so maybe that could be why I don't do it. But we measure things differently at Ben Hogan because we take a lot of stuff for research. So that's the same way every single time. So that's how we do things. But if you're doing a functional test on, functional range of motion with somebody and you're bringing them up that is not an athlete here every day, like Cass said, 6-year-old lady who owns a belly, you're not going to need to make sure that they're in that position every time. You just want to find what's important for you to measure which range that they're difficulty going into, and then getting to that range, taking it past the
I would just advise that find what works for you and just stick to it. Because you're going to be most likely the one that continues to measure your patient throughout. And then if somehow you're not, you always want to document where and in what position you measure them in. So for example, Craig said you could do like ER at 0, put ER at 0 equals